Today we're going to cover inflammation. First of all, we're going to give an overview of the function of inflammation in the body, describe the events that occur during both acute and chronic inflammation. We're only going to go this at a very overview level, so you can go into it in more depth at a later time. And then we'll just briefly go over the drugs that are used to treat and manage inflammation. So what do you already know? I want you to list to me the 5 signs, classic signs of inflammation, and also state why inflammation is actually important. Press pause and do this bit of work. So the 5 signs of inflammation: redness, swelling, heat, pain, and perhaps loss of function. So sometimes you lose function, sometimes you don't. Why is inflammation important? Well, of course, it aims to protect the tissue and maintain homeostasis. And it'll help to slow the spread of any engulfing microorganisms that might be present. It is non-specific in its very nature, and it like I said, it's aimed to remove harmful objects, such as pathogens, which include bacteria and viruses. It enables tissues to heal. That might be scar tissue, or it might be repair of the tissue itself. But it can injure normal tissue too. And as it can damage normal tissue, we use anti-inflammatories to try and inhibit that damage of our normal tissues, but also to help reduce the pain associated with inflammation. So now we're going to just go over acute versus chronic inflammation. So acute inflammation is a relatively short duration, so minutes to hours to days, whilst chronic is a lot longer, generally greater than 2 weeks. What do you already know about acute and chronic inflammation? So duration, that should be nice and easy for you. What type of white blood cell infiltrates an acute inflammatory spot and a chronic one? Do we have an exudate? So this is the definition of an exudate. It's fluid that enters from the blood into areas of inflammation and includes serum, proteins, and white blood cells. Whereas a transudate is fluid that's generally pushed through a capillary due to pressure changes. Therefore, transudates are caused by increased hydrostatic pressure or decreases in oncotic pressure. For example, they aren't changes induced by inflammation. The important difference between them, apart from the causes, of course, is exudate contains protein, transudate does not contain protein, so therefore it looks clearer. And thinking back to the table again, tissue injury, how bad is it? Or potentially, how bad is it? So duration, acute is short, chronic is long, nice and easy. What's the type of white blood cell that comes in? Acute is neutrophils primarily. They're the most abundant white blood cell, and they're recruited to the site of injury within minutes following a trauma, and they're a hallmark of acute inflammation. Chronic inflammation is mainly monocytes, which are circulating in the blood, and then they become macrophages once they enter the tissue. Exudate in acute, yes, we do form an exudate. In chronic, generally no. Tissue injury in acute inflammation, usually mild and self-limiting, whereas in chronic inflammation can lead to tissue destruction and scarring. So there are lots of triggers of acute inflammation. They include things like trauma, infectious organisms, and of course their toxins, tissue necrosis, so tissue death due to ischemia, or down to chemicals. And the inflammation aims to remove the trigger and any potential dead tissue from the site. So if we're looking at the initial stages in acute inflammation, we get that inflammatory response occurring. It's characterized by the rapid infiltration of neutrophils and edema response in response to that injury. And those neutrophils, they provide the first line of immune defense by migrating to the site of injury, neutralizing invading microorganisms or noxious materials by phagocytosis. We then hit into the resolution phase, and here you can see the neutrophils are dying, they undergo apoptosis, and they are ingested or eaten up by macrophages that have emigrated slowly from the inflamed site, from the blood into the inflamed site, and then they're taken away and drained through the lymph nodes. So remembering, in acute inflammation, we're mainly getting neutrophils doing the job, but macrophages are involved in getting rid of the apoptosed neutrophils. So now we're going to talk about how this actually happens in a little bit more detail. And it's split into two stages. We have a vascular stage, which is about the blood vessels, and we have the cellular stage, which is about the cells. And when we're thinking about the vascular stage, we're thinking about the blood vessels and the changes in flow, blood flow, and the changes in diameter. So it's the first stage where the chemical mediators that are released in response to cell death induce vasodilation in the affected tissue. Those chemicals include things like histamine and prostaglandins, for example. And because we've got vasodilation, we've got an increase in our blood flow to the damaged tissue. And that increased blood flow leads to two of the symptoms, warmth and redness. The capillaries increase their permeability by increasing the gap between the endothelial cells. And these are your capillaries become leaky. And so therefore your neutrophils start to infiltrate. And that's the first part of that image that we've shown. The plasma proteins and the plasma oozes into this interstitial fluid, and that's an exudate, remember, because it's got plasma proteins coming in through these leaky endothelial gaps. And that leads to the next symptom, which is edema. And then we have chemical mediators that sensitize our sensory neurons, and that leads to pain. So all they're doing is they're sensitizing sensory neurons to increase the frequency of pain transmission to the brain, for that same signal. So thinking about sunburn, you get acute inflammation because of a sunburn, you touch your skin and that causes pain, whereas normally it wouldn't. And that's because these chemical mediators have sensitized your nociceptors, your pain receptors. So that's the vascular stage. So the next stage is the cellular stage. So it's all about the cells. So your white blood cells, your neutrophils first, because they're smaller, they squeeze through those gaps in between the endothelial cells. They eat or engulf pathogens, they engulf dead cells, and they engulf cell debris. And they also help to recruit other immune cells. They also produce pyrogens. And pyrogens are fever-inducing substances that can inhibit the metabolism of some microorganisms, hence why they're released, therefore making them more susceptible to attack from our inflammatory cells. But of course, these pyrogens cause drowsiness. They increase the body's energy usage and increase stress responses. So in our first stage, in this example, we're using a pin with bacteria on it, and we've got a pinprick. So these bacteria and other chemical are damaging the cells, so we've got tissue injury, releasing a variety of chemical signals. That leads to vasodilation and increased capillary leakiness, and we get neutrophils migrating into that area, along with fluid and along with proteins. So that's leading to our edema. And then, as we start to go into that resolution phase, the neutrophils consume the bacteria and cell debris, and then the macrophages come in and consume those neutrophils that have undergone apoptosis. So it's resolved when the harmful stimulus is eliminated, and as inflammation ends, repair processes begin. But there are lots of chemicals, and I'm only going to touch on 3 or 4 of those chemicals that are involved in inflammation. So histamine is the first one we'll talk about. And so histamine causes vasodilation, which leads to warmth and increased delivery of blood products to the damaged site. It also leads to redness, and it can also lead to itching. It also leads to endothelial gapping, which is your capillary permeability, which allows your neutrophils to enter and your exudate to enter the swelling site as well. And those neutrophils, they of course engulf cell debris and microbes, etc. So that's the purpose of getting those neutrophils in. We have the prostaglandins. They also cause vasodilation, leading to warmth. And they also stimulate our sensory nerve cells, so make them more sensitive to that stimulus. So therefore, they are leading to pain. We have thromboxanes. They stimulate platelet aggregation and therefore clotting. And we have complement. And the complement system complements the immune system. It attracts your white blood cells to the injury site by chemotaxis, causing the release of histamine and creating pore in the membranes of cells, causing them to burst and die. For example, cancer cells and bacteria. So the acute inflammatory responses or inflammation effects, they can be local or they can be systemic. And if they become systemic, you get systemic effects. So you may include a fever, tiredness, anorexia, so you don't want to eat too much, increased heart rate and blood pressure, chills, accelerated destruction of skeletal muscle proteins, and of course leukocytosis, which is an increase in your white blood cell count. And these systemic effects are all mediated through the pyrogens, which are going on to stimulate prostaglandin release and a whole array of messenger signals. So as a summary, you might get injuries. This might be a burn or a microbe. Your cells get damaged in that area, which go on to release chemical factors. And we've talked about what those chemical factors might be. So your histamines, your prostaglandins, thromboxanes, etc. Your blood vessels vasodilate, leading to redness and heat. You get increased vascular permeability, leading to swelling. You get neutrophil infiltration as you get that vascular permeability increasing, leading to phagocytosis. And you get pain receptor sensitization, which leads to pain. So in all, leading to your cardinal signs of redness, warmth, swelling, pain, and potentially, if you're affecting an entire system, loss of function of that system or that organ. So review questions, have a look at these and press pause and have a think about each answer. Which of the following are correct regarding inflammation? Number 1, tissue damage causes levels of chemical mediators such as histamine and prostaglandins to reduce. That's incorrect, of course. The damage to the cells increases the levels of these chemical mediators. 2, chemical mediators cause localized vasoconstriction and increased capillary permeability. That is also correct. They cause localized vasodilation and increased capillary permeability, which of course, that vasodilation leads to warmth. Number 3, exudate forms in the interstitial space due to increased capillary permeability. That is correct. Remembering your exudate contains proteins. Number 4, neutrophils enter the interstitial space and engulf microorganisms and cell debris. That is, of course, correct. We'll just touch on chronic inflammation now. And this is where you have low-level inflammation, which is affecting various parts of the body for prolonged periods, causing tissue destruction and scar tissue buildup. It can be due to illness and disease lifestyle factors, for example, smoking, alcohol, and obesity. And in fact, inflammation is common in a lot of autoimmune conditions, such as rheumatoid arthritis, multiple sclerosis, type 1 diabetes, and thyroid diseases. So when you get this injury, whatever that injury might be, so because of viral infections, chronic infections, injuries, autoimmune disease, or these chronic factors, can lead to chronic inflammation with angiogenesis, your macrophage infiltration, and your scar tissue buildup. And as they start to heal, you get the fibrosis, and therefore as your tissues have now fibrosed, they're losing that function. So long-term inflammation can obviously significantly impart your quality of life, increase your risk of developing serious illness, as well as affecting your mental health. So that constant low-level chemical release damages blood vessels walls, damages organs, depresses the immune system, increases the risk of cardiovascular disease, myocardial infarction, stroke, renal disease, diabetes, irritable bowel syndrome, arthritis, cancer. The list just goes on. But of course, we can help to reduce chronic inflammation by having a healthier lifestyle. So a better quality and longer sleep, stress management, healthy diet, increased exercise, don't smoke, healthy weight, etc. All the common sense factors that we can affect. So I'd like you to just complete this table comparing chronic and acute inflammation. We've done it once, and all we're doing is a second time. Duration: acute, fast, minutes to days. Chronic, slow, around 2 weeks or longer. Which white blood cell is the primary infiltrate? Mainly neutrophils. For acute, mainly monocytes, which are then converted to macrophages in chronic. Exudate: yes in acute inflammation, no in chronic inflammation. To get tissue injury: in acute, it's usually mild and self-limiting, whereas in chronic, it's tissue destruction and scarring forming. What are the local and systemic signs of inflammation? Just simple. Are we thinking prominent or not so prominent? So do we see lots of local and systemic signs of inflammation in acute? Well, yes, we do. They're obvious. What about in chronic? Can you tell by looking at someone? Do we have those obvious local or those obvious systemic signs of inflammation? Can you tell someone has those systemic or local signs? And the answer is it's less obvious as a general rule. So the final part we're going to do is look at the management and treatment of inflammation. So of course, lifestyle changes are important in the long-term management of inflammation, in particular when you're thinking about chronic inflammation. And as I've said, you want to increase your sleep or have higher quality sleep, stress management, healthy diet, alcohol moderation, increased exercise, quit smoking, healthy weight, all the things that we can modify ourselves. But we do use drugs to treat and manage inflammation. What drugs do you know about that are anti-inflammatory? So press pause and just list the general type of drug. So we have the non-steroidal anti-inflammatories, the NSAIDs, such as aspirin and ibuprofen. We have the corticosteroids. So these are steroidal anti-inflammatory drugs, which are based on cholesterol. So hence it's a steroid hormone. So it's based on the cholesterol steroid hormone cortisol. So it has strong anti-immune and anti-inflammatory properties. We have antihistamines. And we have paracetamol. This is not anti-inflammatory. It is analgesic, yes, it reduces pain, and it's antipyretic, so it reduces your temperature, so it reduces the chance of fever, but it is not anti-inflammatory. So the other ones, NSAIDs, corticosteroids, antihistamines, yes, anti-inflammatories. Paracetamol, often thought of as anti-inflammatory, is not. Though it does have good effects. So anti-inflammatory drugs. Tissue injury causes the production of chemical mediators which activate inflammation. We've talked about each of those different types of chemical mediators, and I will just go through this in a different way, but also highlighting where drugs potentially work. So we get some tissue injury, we start to release our chemical mediators. One of those is histamine, which induces vasodilation and increases capillary permeability. Your antihistamines work there. Your damaged cell membrane also releases a variety of substrates, and your corticosteroids work at this point. They help to stop the release of the damaged cell membrane at this point. And if we're looking at the pharmacodynamics, corticosteroids prevent the formation of chemicals that mediate inflammation. And those chemicals, remember, are stimulated by cyclooxygenase. They stimulate the release of prostaglandins, and that they lead to vasodilation and sensory nerve sensitization. So therefore, they're causing vasodilation and pain. At the same time, we have the thromboxanes, and they lead to platelet aggregation and therefore clotting. So of course, your NSAIDs, your non-steroidal anti-inflammatory drugs, work there. They're COX inhibitors. So you're thinking about your aspirin, for example. If we're looking at the pharmacodynamics of NSAIDs, these are anti-inflammatory, antipyretic, and analgesic rather. As I've said, the NSAIDs do have some serious side effects, not so much as the corticosteroids, which are much nastier again. But the NSAIDs, they can irritate the lining of the GI tract because the prostaglandins are protective of the GI lining. So therefore, we've got less prostaglandins, so therefore potentially more damage. Some of them are also acidic. Some of the NSAIDs are acidic, which can further damage the GI tract. And of course, NSAIDs are competitive inhibitors of the COX-1 and 2 enzymes. So like we said, the NSAIDs are competitive inhibitors of the COX enzyme. So if you have some tissue damage, you're damaging your membranes, releasing the substrate. That substrate reacts with the COX-1, 2 enzymes, and you get a large amount of prostaglandin release, which means you have a high inflammatory response. If you are treating with NSAIDs, you still get that phospholipid damage, you still get that substrate forming, but now the NSAID is competing for the enzyme active site. So we therefore get less prostaglandin release and therefore a lowered inflammatory response. So when do you use what anti-inflammatory drug? So on the left you can see just that diagram again showing the NSAIDs, so there, the corticosteroids there, and we have our antihistamines, which aren't shown in this image, of course. So when do you use them? Well, first of all, remember the corticosteroids, they're strong, they're anti-inflammatory, and they are immunosuppressants. They are used to treat a range of conditions such as asthma, skin diseases, hormonal insufficiencies, and tumours. The steroids tend to affect more systems. They can affect your immune system, your inflammatory system. They affect metabolism and your electrolytes, for example, sodium. So they can affect a wide variety of systems. The NSAIDs, they are anti-inflammatory and antipyretic and analgesic. They have less serious side effects compared to the steroids, but those side effects do include GI disturbances in particular, so ulcerations, but also skin reactions. And as I've said, the corticosteroids tend to have much more serious effects because they affect more systems, and so they can suppress your response to injury or infection, so immunosuppression. And they also have a variety of metabolic effects. They increase blood sugar levels. They stimulate protein breakdown, so can lead to osteoporosis because of that protein degradation. So they have a multitude of side effects. So you would not use those primarily when you're treating someone if you could avoid it. So, review question. Press pause and have a read through this. Possible effects of anti-inflammatory drugs are: NSAIDs reduce prostaglandins, which are protective of the GI tract mucosa. NSAIDs may therefore lead to GI ulcers. That is correct. Corticosteroids suppress the immune system, so there may be a reduced response to injury or infection. That is also correct. Number 3. Corticosteroids stimulate protein degradation, so long-term use may lead to osteoporosis. That is also correct. The last little thing I'd like you to think about is like a short answer question. I want you to describe the pathophysiological processes that underlie the following signs of inflammation. So what are the mechanisms behind pain, redness, and swelling? So press pause, have a think. Now you've unpressed pause, and hopefully you know the answer because it's all in this session.